run parallel to the incus. If you run parallel to the incus, your facial nerve is always below.
Sometimes during this step, the posterior canal wall is more posterior, and it may actually the burr may actually hit the posterior canal wall. So what strategy one can use at this point?
Yeah, see, canal wall variations you can see from case to case. It may vary, the curvature of the canal wall may vary case to case.
Yes.
Now see, I have seen both the nerves.
Yeah.
What I am trying to show you, see this. I was running my drill parallel to the incus. Can you see?
Yes.
To uncover the facial nerve which is below. Now I am, see, just to show you, raising a magnification one level up. Can you see? Can you see both the structures together?
Yes, sir, we can see.
This is the facial nerve. Hello?
Yes, sir.
And this is the chorda tympani. Chorda tympani arises from the facial nerve mostly just above the or superior to the stylomastoid foramen. Oh, the picture is okay?
Satish boss, it's a very narrow facial recess, or it's
No,
you see
it doesn't
normal?
look like. Maybe.
Yeah.
But see, all these dimensions in the temporal bone, middle ear, facial recess are same what they are at the time of birth. It's side body. Yeah, they never, only the curvature of the oxyartery canal may change, but the dimension of the middle ear structures, this facial recess, they remain same.
Yes.
Now, let me see this relationship better. Just to show you, can you see the chorda rising?
Yes.
Very clear?
Very
Yes,
clear.
yes.
Yes.
See the chorda rising from the facial nerve. And this facial nerve, see this digastric ridge. See this digastric ridge and the facial nerve relationship. See this? This is digastric ridge and this is facial nerve immediately medial to it. Can you see very clear?
Clear, boss.
Now, this chorda is a great landmark to protect the annulus. That's why chorda is considered, and we go. See this chorda?
Can you center the picture, boss?
Yeah. Can you see the space
Yes.
between the chorda and the facial? Better?
Better.
And the space between these two is going to be the facial recess. See both the nerves. So clear. And see the incus and the relationship of facial nerve. Facial nerve is always deep to the plane of the incus. Always, always. Use the landmarks which are more reliable.
ऐसे देखो अभी इसके बर्फ इधर लग रही है थोड़ी सी जाके
Boss, you are using 2 mm burr now? 2 mm?
This is 2 mm burr now.
Yes.
अच्छी लग रही है इधर ना
Now, in order to get more space, where the nerves are diverging, I need to go little superior. I can go up to some millimetric distance from the fossa incudis. See this?
So,
वही बन रहा है ना
boss, hardly any cell there in the the facial recess. Yeah.
It is not nematized that way.
Yes, boss.
So
That landmark cell, that what we call that,
yeah,
the
it is
cell.
mostly you find otherwise.
Greenwald, yeah.
Mostly you find otherwise.
Yes.
You know, the nematization pattern is different for different people. Normally in cochlear implant, those cases are, infection-free cases. Those have a straightforward anatomy as compared to the other individuals. See this?
Yeah,
Now,
we can get a glimpse of the IS joint now.
yeah. Now the important thing at this point, before entering, I can see the glimpse of the round window niche. Glimpse.
Yes.
But still further, I will widen this space before going to the, directly to the cochlea. I will widen all around to get the maximum space before going deeper. And see, this is anterior thinning of the facial ridge. Can you see the tendon?
Yes, you can see. You can see the pyramidal process also.
Yes,
And
pyramidal process and the tendon. And see this thick bone anterior to the facial now. This is anterior thinning of the facial ridge. See that? This is anterior thinning. See how much space we have gained now.
boss, how to prevent the shaft injury to the
Yeah,
facial at this stage?
For such times, you need to have a long, sharp tapering burst. Long tapering burst to protect the facial nerve from, getting unnecessary injured.
Boss, have you ever done the out fracturing of the external
I can
auditory?
see the round window.
Satish boss,
Huh?
have you ever done the fracturing of the external auditory canal in narrow recess cases?
Yes, we have done twice. That is simple process, body de cutting. That is a simple process. What you need to do in all those difficult anatomy and narrow recess, you can simply, I can make a cut over here and cut over here. Just only the bony cut, keeping the tympanomeatal flap intact,
Okay.
and push it anteriorly. We can deposit it later on. We can deposit and put some bone dust later on
Okay.
without any problem. So I am thinning a little bit to give more tilt. This is thinning of the canal wall. To cardiac figures. See, this is thinning of the canal wall.
Yes.
Now, look at this.
Yeah, we can see the round window now. Complete
Yes,
window niche
correct. See the bluish round window?
and the hypotympanic cell also. Round window membrane is also seen.
Yeah, so this is a favorable patla de.
Yes.
It is a favorable, I would say, round window with hardly any niche patla. Patli de. See, little bit of the niche over it. Can you see?
Yes. Very small ledge of bone. Yes.
Yeah, $0. Oh, रुक जा भाई. This little bit of the niche. See now more and more round window coming into the view. Patla debar. This round window is the backdoor entry to the scala tympani. See now round window completely uncovered. See this round window
Yeah, round window. Yeah,
membrane.
Nick given now.
just to open up.
Yes. We can see the
See
scalar
this?
cavity.
The scala tympani. And this is a favorable round window, I would say. It's a favorable round window in the sense this is not posteriorly rotated.
Yes.
Now, one thing, if I push my implant, patla dena bilkul pit tight. We'll uncover the inner anatomy and show you. See, if I push my implant, if I go straight, see where my instrument is touching
Yes.
the modulus.
Modulus, yeah.
So to avoid the implant touching the modulus and going in the lumen, you need to come from above like this.
Yes.
See this scala here is inferiorly directed and then anteriorly turning. So in order to make that implant going straight in the lumen rather than going into the onto the modulus, what you can do, but it is not much required in this case. What I can do is remove the inferior lip of the
Round window.
round window. Now see, there are important structures in relation to it. If you drill, let me tell you. Anteriorly, if I drill anterior to it here,
Enter the picture, boss.
yeah.
Yes. Okay now.
Suppose if I drill anterior to here, anterior to the round window, this is the region where the basilar membrane is running.
Yes.
Try to understand. Never ever try to drill anterior to the round window. I will tell you exactly where the basilar membrane is coming, will open up. Medially, we are not supposed to run in the medial wall like this here. So medially are the openings of the cochlear aqueduct and the inferior cochlear vein in the medial wall. See, I am going in and in the medial wall. Can you see there?
Yes.
The safest region which you can easily widen
Inferior.
and make straight.
It's inferior. Yeah.
This is crista.
Yes. So this outer lip is crista, boss.
Yes, possible.
So
You can remove the crista safely and then your implant will have a straight axis. Crista is very, very safe to remove.
Satish was, is it you remove crista in every case, even when you are using slim electrodes?
Whatever. See, the reason is I want my electrode to stay in the scala tympani. Now see the depth of the scala tympani.
Yes. We can
See
get the
See the straight shot.
yes.
Now when I push my implant, it is going to go show. Let me show. Bilkul patla. It is going to go straight in the lumen. See that? Now I turn my view and see this. This implant is going to go straight in the lumen. Can you see?
Yes.
Hello?
Yes, we can see, boss. It's a very we can see the part of the basal one of the cochlea. Yes, in the
See
scala.
medially, if I turn
We can
medially,
see
see
the
inside. See inside, if I turn
modulus.
medially, is the modulus.
Yes.
And if I turn this way, this is the straight lumen in the scala tympani. Can you see very clear or not?
Yes, very clear.
So we want the implant to go straight in the lumen. And for that, what all you need to do is widen the round window inferiorly. That's it. Widen the round window inferiorly, nothing else is required. And we have a straight shot, we can insert or implant straight into the lumen.
Well,
Now,
can you show with Prolin if you have by putting it in?
I will show. I'll put my silo endoscope also later.
Okay.
Now,
Oh, great. That's
This
wonderful.
cochlea, if we unveil the anatomy of the cochlea, this is the scala tympani. Superior to that, superior to this scala tympani, this is the inferior lumen. This scala is all around the modulus with 2 and 3/4 tons. There are 3 lumens which are running all around the annulus for 2 and 3/4 tons. And one of them lumen, the biggest one is the scala tympani, which we are seeing. And this scala tympani is closest to the modulus. So we preferentially want our implant to stay in the scala tympani. Got my point?
Yes.
This is the closest to stimulate the spiral ganglion population in the modulus. Now, this scala tympani is out of the 3 lumens. Where are the other 2 lumens? Where are the other 2 lumens? We need to see. To see the other 2 lumens, we have to uncover the inner ear further. Okay? This
Yes.
is one lumen, which is the preferential lumen scala tympani, which we want to implant. Now, what are the other lumen? What happens if the implant goes to the other lumen? How we can avoid entry into that? How the anatomy is and how this implant goes around the modulus? What are the other alternative things we will see once we uncover the anatomy of the cochlea? Okay? Hello?
Yes. Yes, boss.
So let me first remove the canal wall and first remove the canal wall and show you the entire cochlear anatomy. Okay?
Okay, boss. So you will do canal wall down now.
Yeah. Just to show you anatomy.
Okay, boss.
If patient we have to implant, you can implant it right now without any issues. But to uncover the anatomy, we have to go, just the sake of demonstration of the cochlear anatomy, I have to go further.
Kindly centralize.
And sir, please also show the singular nerve, how to do transcanal singular neurectomy.
I will show you the place for the singular neurectomy also. Singular neurectomy is a Gessex procedure. It was a Gessex who popular